So if you picture October 1918, the United States Public Health Service, or the PHS, is suddenly handed this totally unprecedented emergency budget.
Right. $1 million.
Exactly. $1 million, which, was a massive amount of money back then. And they've got the top scientific minds of the era on their payroll.
The absolute best.
Yeah. And they're watching this biological disaster just tear across the globe. It's accelerating toward their own borders with terrifying speed.
It's just moving incredibly fast.
Right. But here's the crazy part. Legally and constitutionally, they could not force a single local mayor to close a single neighborhood saloon.
They had zero direct authority over that.
Nothing. So today we're doing a deep dive into the deadliest public health catastrophe in American history, the 1918 influenza pandemic.
Yeah.
But, we aren't just looking at the tragedy of it. We're examining what happens when unlimited science collides with bounded legal authority.
Which is such a crucial tension.
It really is.
Yeah.
And we'll see how that specific collision actually forged the modern tools of epidemiology that we still rely on today.
The structural tension of that moment is it's incredible. You have a federal agency tasked with protecting a nation, equipped with state-of-the-art medical intelligence for 1918.
Right, the cutting edge for the time.
Exactly. But they're fundamentally stripped of the executive power to actually mandate localized survival.
Okay, let's unpack this, because we're pulling from a massive dossier for this deep dive.
Oh, yeah, the source material is extensive.
Yeah, we have primary records from public health reports, documents from the National Archives, special mortality tables from the U.S. Census.
And the Navy's own historical accounts.
Right, plus the University of Michigan's digital encyclopedia, which tracks all these city-by-city responses. But we need to start by just wrapping our heads around the sheer gravity of this pathogen.
The numbers are hard to even process.
They really are. For you listening, we were talking about roughly 675,000 Americans dead in a matter of months.
In just a few months.
Yeah. I mean, that mortality figure, it eclipses all the combat deaths of World War I, World War II, Korea, and Vietnam combined.
It's just staggering. And, the velocity of the dying is really what overwhelmed the system.
How so?
Well, we usually look at seasonal influenza mortality through the lens of what we call a U-shaped curve.
Okay, a U-shaped curve.
Right. So the highest mortality rates sit at the extremes of that curve. You have infants with underdeveloped immune systems on one end.
Right, the very young.
Exactly. And then the elderly with waning immune function on the other end. So it makes a U.
Makes sense.
But the people in the middle, like healthy adults in their 20s and 30s, they might catch the virus, but they generally recover.
Right, because their immune systems are, operating at peak efficiency.
Exactly. But the 1918 virus mutated that demographic expectation into the infamous W-shaped curve.
A W. So there's a spike right in the middle.
A massive spike right in the middle of the graph. The very people who should have been the most resilient soldiers in prime physical condition, factory workers, young parents, they were dying at staggering rates.
Which is terrifying. I mean, why was it hitting the strongest people the hardest?
The mechanism behind that W curve is what makes it so uniquely horrifying. Modern retrospective epidemiology, looking back at the data, it suggests that the 1918 strain triggered what we call a cytokine storm.
It's a cytokine storm.
Right. The virus basically provoked a massive overreaction in the host's immune system. So the stronger your immune system was, the more violently it responded.
Oh, wow. So your own body is fighting too hard.
Exactly. It essentially flooded the lungs with fluid and inflammatory cells. So the body's own robust defense mechanism literally became the instrument of death.
That's just nightmare fuel. And that resulted in a precipitous 12-year drop in average U.S. life expectancy, right? Just for the single year of 1918.
Just for 1918. 12 years wiped out.
When you see a demographer's chart from the 20th century, that 12-year drop looks like an error in the data. It's just a vertical plunge.
It's a complete anomaly on a graph.
Yeah. But to understand how the federal government tried to manage this disaster, we really have to look at the preliminary wave in the spring of 1918.
Because they weren't totally blindsided.
Right. Surgeon General Rupert Blue, he wasn't entirely caught off guard.
No, Rupert Blue is a fascinating figure to anchor this narrative. He was a career officer, and he'd actually previously made his name by eradicating the bubonic plague in San Francisco.
Right, in the early 1900s.
Exactly. So he really understood the mechanics of an outbreak. He understood vectors, containment, public messaging. He wasn't just some politician playing doctor.
Yeah, he knew what he was doing, because in April 1918, which is months before that catastrophic fall wave, he actually established a PHS Influenza Task Force.
He saw it coming.
He did, and he put this brilliant epidemiologist named Wade Hampton Frost in charge of it. So you have this proactive federal apparatus trying to build essentially a radar system for this specific threat.
Right, they're setting up the early warning bells. But the spring wave essentially provided a biological head fake.
A head fake, so it looked like they had it under control.
Yeah, exactly. It began moving through military camps and civilian communities, and it had very high transmissibility, lots of people getting it, but relatively low lethality.
So people were getting sick, but not dying at those crazy rates yet.
Right. You had massive numbers of soldiers falling ill at places like Camp Funston in Kansas, which, by the way, is heavily cited in popular history as a potential point of origin.
The famous Camp Funston theory.
Yeah, though the true geographic patient zero really remains a subject of intense historical dispute among scholars.
And part of the reason for that dispute, right, is because the viral tracking was heavily obfuscated by wartime censorship.
Absolutely.
Which actually brings up the name. We almost always hear it called the Spanish flu, but that's a complete misnomer.
It is. The name is entirely an artifact of geopolitical information control.
Okay, tell me more about that.
Well, in 1918, the world is locked in the existential meat grinder of World War I. So the United States, Britain, France, Germany, the combatant nations, they all viewed morale as a critical strategic asset.
Right, you can't show any weakness.
Exactly. If a virus is sweeping through your training camps and trenches and debilitating your fighting force, the last thing you do is publish that information in the newspaper for enemy intelligence to read.
So you embargo the news, you censor the medical reports.
You completely lock it down. But Spain was neutral.
Spain wasn't fighting.
Right, Spain was not a combatant, so their press operated without that specific military censorship. When the virus crossed their borders and subsequently infected King Alfonso XIII, Spanish newspapers documented the outbreak in exhaustive detail.
But just reported the news like normal.
Exactly. So if you were an intelligence officer or a civilian reading the international wire services in London or Washington, the only dispatches describing the strange new illness were coming out of Madrid.
Oh, wow.
So the illusion was created that the virus was a uniquely Spanish phenomenon.
It's literally just a narrative born entirely out of an information vacuum.
Exactly.
But, you know, back in the U.S. during that spring wave, the virus didn't seem apocalyptic. The military managed the localized outbreaks, the task force gathered basic data, and then the virus just seemed to kind of recede into the background over the summer.
Right. The system appeared to be functioning perfectly. Wade Hampton Frost and the task force had their surveillance protocols in place.
Right.
If you're Rupert Blue, you might reasonably look at the situation and conclude that the PHS is totally capable of managing whatever this pathogen throws at you.
Like watching the ocean draw back before a tsunami. Did this mild first wave essentially act as, like, a trap, making the PHS feel way more prepared than they actually were?
That's exactly what it was.
Right.
Because biological pathogens, they don't respect bureaucratic timelines. Over the summer, the virus underwent a genetic shift.
It mutated.
It mutated significantly.
Yeah.
And when it roared back in August and September, it was a fundamentally different beast. We moved from a manageable outbreak to a scenario that just breaks the bounds of medical comprehension.
Yeah, let's look at the outbreak at Camp Devens in Massachusetts, which was one of the really early epicenters of that second wave.
Camp Devens is a terrifying case study. It was a mobilization hub designed to process thousands of troops for the European theater.
Right, guys getting ready to ship out.
Exactly. It was incredibly crowded. The men were sleeping in very close quarters.
Yeah.
And it just created the absolute perfect incubation environment. When the mutated virus arrived there, the mortality was explosive.
I was reading through the primary sources from the medical officers who were stationed there, and the physiological descriptions of the dying men are just horrific.
They're very difficult to read.
Yeah. Dr. Roy Grist, who was a physician at Devens, he wrote about patients arriving with what looked like normal influenza, but within hours, they would develop this deep mahogany spot on their cheekbones.
Right, the mahogany spot. That is the clinical manifestation of severe cyanosis.
Cyanosis, so oxygen deprivation.
Exactly. The virus was causing such rapid and catastrophic damage to the alveoli, which are the tiny air sacs in the lungs where oxygen exchange occurs.
Okay.
The damage was so severe that the blood was literally being starved of oxygen. The patients were turning blue, starting at the extremities and the face, as they asphyxiated from the inside out.
Asphyxiating from the inside out, that is unbelievable. And the speed of it is the variable that really overwhelmed the medical infrastructure. Right?
It was incredibly fast.
I mean, a soldier could report to the infirmary feeling mildly fatigued at breakfast, be exhibiting severe cyanosis by dinner, and be dead before the next morning.
In less than 24 hours.
You just couldn't build hospitals fast enough to warehouse the sheer volume of critically ill people. And, it wasn't isolated to the camps. The military was packing these soldiers onto troop ships to cross the Atlantic.
Which was a massive logistical error, epidemiologically speaking. The troop ships function as these floating biological time bombs.
I can't even imagine.
The virus just tore through the holds. And as the military moved men along the national rail lines to get to the ports, the civilian populations intersecting with those logistical arteries were exposed.
So it's spreading out from the tracks.
Exactly. The geographic spread vastly outpaced any existing mechanism of containment.
And this brings us to a moment in legislative history that feels almost alien today.
It really does.
We have this rapidly accelerating national disaster. And Senator John W. Weeks of Massachusetts, who is, watching his state get battered, he stands up in Congress and demands a $1 million emergency appropriation for the Public Health Service to combat and suppress the influenza.
$1 million for public health intervention in 1918 was an astronomical, paradigm-shifting sum.
Like, they didn't even have a mechanism for it.
Exactly. The federal government did not have a strong precedent for directly funding local disease suppression on that kind of scale. The expectation was always that local municipalities handled local outbreaks.
Right. Yet it passes both houses of Congress without a single dissenting vote. Unanimous.
Every single vote.
A total, immediate federal mandate handed directly to Surgeon General Rupert Blue.
And Blue recognized this as a watershed moment. He believed this unanimous appropriation would permanently cement the federal government's role as the ultimate guarantor of national public health.
He's finally got the resources.
Right. He had the funding, he had Wade Hampton Frost Task Force, and he had the clear political backing of Congress.
But here is where we hit the core paradox.
Yes.
I look at this dynamic like an architect building a house. The federal government, the PHS, they are the architect. With that $1 million, they can draw the most brilliant blueprints.
Beautiful blueprints.
They can hire the best consultants. They can even purchase a massive pile of bricks and just drop them on your front lawn. But legally, they are completely barred from pouring the foundation.
Exactly.
If the local mayor decides to use those prompts to build a patio instead of a storm shelter, the architect just has to stand there and watch the house fall down.
What's fascinating here is that your architectural analogy maps perfectly onto the concept of borrowed and bounded power.
Borrowed and bounded.
Right. The Constitution designates police powers, which is the authority to enact laws that protect the health, safety, and morals of the public to the individual states.
Okay, so the states have the real power.
Exactly. And then the states delegate much of that power to local municipalities. The federal government controls interstate commerce and international borders, sure.
Right, that big picture stuff.
But it possesses absolutely zero executive authority to tell the mayor of a city to shutter a private business, close a school, or mandate the wearing of masks.
Wow. So what did the PHS actually do with the $1 million? If they couldn't mandate closures, they must have pivoted to logistics, right?
That's exactly what they did. They became a massive recruitment and distribution network.
Okay.
They utilized the funding to hire thousands of private physicians and nurses, partnering heavily with the American Red Cross. They essentially created an expeditionary medical force that they could dispatch to the hardest-hit states.
So they're shipping out the personnel?
Yes. They supplied the labor and the funding, but they were handing those resources over to local authorities to actually deploy on the ground.
And Rupert Blue tries to exercise his moral authority, right? Because on October 5th, 1918, he issues this comprehensive piece of federal guidance.
He does.
He's explicitly urging state and local officials to close or suspend places of public assembly. He's basically telling them, shut down the churches, the schools, the theaters, the saloons.
He is projecting his scientific authority as loudly as possible, just hoping to influence the execution of those local police powers. The tragedy of the 1918 pandemic is not that the federal government lacked a plan. It is that the federalism structure inherently fragments the execution of that plan into thousands of individual local decisions.
Which leads to a jarring disparity in survival rates across the country. I was digging into the University of Michigan's digital encyclopedia on this, comparing specific city-level outcomes.
Oh, the variance is wild.
Yeah. The contrast between Philadelphia and St. Louis is like the textbook illustration of how those local decisions actually played out.
The tale of those two cities perfectly isolates the variable of timely local intervention. Let's look at Philadelphia first.
Okay. So in late September, the virus was already present in Philadelphia's Navy Yard. Civilian doctors were warning the local public health director, a guy named Dr. Vilmer Cruzen, that a massive outbreak was imminent.
They knew it was there.
They knew. But despite these warnings, Cruzen refuses to cancel the Liberty Loan Parade scheduled for September 28th.
Which is just a catastrophic decision.
Right. He yields to the immense political and economic pressure to sell war bonds for the war effort.
He prioritized the economic and patriotic momentum of the war over the explicit epidemiological warnings. 200,000 people packed the streets of Philadelphia for that parade.
200,000?
They were compressed together, cheering, shouting, sharing the same air for hours.
The biological consequence of that single localized decision was just apocalyptic. Within 72 hours, every single bed in Philadelphia's 31 hospitals was full.
Completely overrun.
Within a week, thousands were dead. The city was literally forced to use steam shovels to dig mass graves because they just ran out of coffins and grave diggers.
It's unimaginable. And Philadelphia delayed implementing Rupert Blue's advice. By the time Cruzen finally ordered closures on October 3rd, the virus had already saturated the population.
It was too late.
Way too late. The mortality curve just spiked vertically.
Yeah.
Now, compare that to the timeline in St. Louis.
Right. So in St. Louis, you have a local health commissioner named Dr. Max Starkloff.
Starkloff, yes.
He sees what is happening on the East Coast. He reads the PHS guidance. And most importantly, he actually has the local executive authority to act.
He has the power.
Right. Just days after the first major cases appear among civilians in St. Louis, Starkloff shuts the city down. He closes the schools, the theaters, the public gatherings. He implements the exact architectural blueprint the federal government provided.
And Starkloff faced immense pushback for that. The business community was furious. Theater owners were threatening legal action.
I'm sure they were.
But he leveraged his local police powers to sustain those closures. And the result is empirically undeniable.
The numbers don't lie.
No, they don't. When you overlay the mortality charts of the two cities, Philadelphia has this massive, sharp mountain peak of death in October.
Yeah, right.
St. Louis has a low, flattened hill. The virus still arrived in St. Louis. People still got sick and died. But the medical infrastructure was never overrun.
We use the phrase flattening the curve today all the time, right? But this is the genesis of that concept.
This is where it comes from.
So what does this all mean for you, the listener? If the Surgeon General's closure order is just advice, isn't federalism inherently a fatal flaw during a rapidly spreading biological crisis?
It's a very fair question. The structural federalism of the United States means that in a biological crisis, your proximity to survival isn't dictated by the president or the Surgeon General. It is heavily dictated by the courage and competence of your local health commissioner.
Wow.
The autonomy to save a community is intrinsically linked to the autonomy to doom it. The federal government can provide the $1 million and the nurses, but local execution is the decisive variable.
That's heavy. Yeah. But as these local mayors and commissioners were fighting these fragmented battles, the scientists back in Washington realized they were facing a completely different, arguably more dangerous structural wall.
A massive blind spot.
Exactly. They literally could not count who was dying.
The morbidity data crisis. This is perhaps the most profound institutional failure of the era, and it fundamentally altered how we practice public health.
Yeah. To lay the groundwork for this, we need to talk about the difference between the case fatality rate, the CFR, and the infection fatality rate, the IFR.
A crucial distinction.
Right. When we look at a pandemic, if we only count the people sick enough to be admitted to a hospital and we look at how many of them die, the virus looks incredibly lethal. That's the CFR.
Right, the hospital data.
But to really understand how a virus moves, you need the IFR. You need to know how many people caught the virus and just had a mild cough and stayed home.
Exactly. Without that data, you lack the true denominator.
Right.
If Wade Hampton Frost is sitting in Washington trying to figure out where to allocate the PHS's limited supply of recruited nurses, he needs accurate data from the states. He needs to know not just who is dying in the hospitals, but the total volume of transmission in the community.
And the primary sources described the state reporting mechanisms as having an utter inadequacy and lack of uniformity. What was causing the breakdown on the ground?
There was just no standardized national framework for disease reporting. Public health was highly localized.
It's just a patchwork.
Exactly. One county might require doctors to report every suspected case of influenza by telegraph.
Okay.
The neighboring county might not mandate reporting at all. Or, perhaps their overwhelmed doctor simply stopped filling out the paperwork.
Which, I mean, if a local doctor is working 20-hour shifts and watching patients literally turn blue, they aren't prioritizing the bureaucratic forms.
Of course not. And beyond the sheer chaos, you have immense selection bias. The data reaching Washington was heavily skewed toward severe hospitalized cases.
Because those are the only ones being recorded.
Right. The thousands of mild cases, the asymptomatic transmission, which is the engine of any pandemic, they were completely invisible to the federal surveillance apparatus.
So Frost is trying to build like a mathematical model of a forest fire, but his only data points are the specific trees that have already burned to the ground.
Yes.
He has absolutely no way of seeing where the sparks are landing.
That's a great way to put it. Faced with this profound informational blindness, the PHS realized they had to bypass the fractured state and hospital reporting systems entirely.
Just go around them.
Exactly.
Yeah.
They initiated a massive brute force data collection effort. Lacking a passive surveillance network, they shifted to active surveillance through house-to-house canvas surveys.
The logistics of this are just staggering to me. The federal government deployed teams of public health workers, partnered with local volunteers to physically walk through communities in the aftermath of that lethal fall wave.
Literally knocking on doors.
Yeah. They divided cities into districts, walked up to front doors, and just asked residents to reconstruct the outbreak. Who lived here in September? Who got sick? What were their symptoms? Did anyone die?
They are essentially conducting a retrospective census of a disaster.
Right.
And the methodological rigor Wade Hampton Frost applied to this process is what elevates it from a desperate Band-Aid to an actual scientific revolution. He wasn't just tallying corpses. He was engineering a standardized mechanism to capture the elusive denominator we talked about earlier.
But how do you ensure accuracy with a method like that? I mean, if you are knocking on doors in December to ask about a chaotic week in October, you are dealing with massive survivor bias and memory decay.
Absolutely. Memory is faulty. But Frost controlled for those variables through strict standardization. The canvassers used identical, highly specific questionnaires across multiple cities.
Oh, so everyone is asking the exact same question.
Exactly. They didn't just ask, did you have the flu? They asked for specific onset dates, symptom profiles, and the exact age and occupation of every single household member.
That's incredibly thorough.
It was. By surveying the healthy as well as the sick within a randomized sample of neighborhoods across cities with different demographic profiles, Frost could build a statistically sound model of the total infection rate.
He is mapping the transmission pathways within individual households. He is proving that you can take the chaotic, anecdotal terror of an invisible pathogen and subject it to rigorous mathematical geometry.
That's beautifully said. And he published these findings extensively in public health reports. These documents are effectively the Magna Carta of American epidemiology.
The founding documents.
Truly, Frost translated the handwritten canvas forms into cross-tabulated tables showing secondary attack rates, age-specific morbidity, and true mortality ratios.
And the transition of this methodology from a makeshift federal survey into a permanent academic discipline, that's really the true legacy of the PHS in 1918.
Without a doubt.
Frost didn't just write a retrospective report and, file it in an archive somewhere. He carried these specific statistical methods into the academy, founding the very first academic department of epidemiology in the United States at Johns Hopkins University.
He established the curriculum. He trained the next generation of scientists to view populations rather than individual patients as the unit of clinical observation.
That's a huge shift in perspective.
It changed everything. The methods he standardized, identifying the true denominator, controlling for reporting bias, mapping household transmission, they became the permanent architecture of disease surveillance.
There is a profound shift in power dynamics here, too. The U.S. Public Health Service ultimately lost the battle against the 1918 virus.
They did.
They could not stop 675,000 Americans from dying. But by deploying Frost and building these rigorous statistical frameworks, they basically replaced the legal authority they lacked with unassailable scientific authority.
Yes.
If you cannot order a mayor to close a city, you build the data model that makes it politically impossible for them to deny the reality of the threat.
What's fascinating here is that they traded a bounded executive power for a permanent scientific influence.
And that transition from raw survey data to standardized academic practice serves as the exact blueprint that community health organizers and national leaders rely on today.
It's the same playbook.
When we analyze the modern pandemic response, the structural parallels to 1918 are striking.
They really are. The virus evolves, obviously. The medical technology advances immensely, but the constitutional and administrative architecture of the public health response remains fundamentally unchanged.
It's the same system.
Exactly. The federal government acts as the funder and the resource provider, while the actual mandates, the school closures, the mask policies, are debated and executed by state governors and local mayors.
The borrowed and bounded dynamic is completely intact a century later.
Completely.
Which is why we need to distill this history into actionable utility. Based on the dossier, there are 3 core lessons from 1918 that serve as a direct case study for modern community health organizers.
Let's hear them.
Lesson number 1. Timely local intervention is the decisive variable.
Because the federal apparatus functions as an advisor rather than a commander, hesitation at the local level is mathematically fatal.
Right.
The comparison between Philadelphia and St. Louis is not a historical anomaly. It is a fixed epidemiological rule.
It's proven science.
When a highly transmissible airborne pathogen emerges, local leaders must utilize their police powers swiftly to flatten the curve. Waiting for a federal mandate that legally cannot come only guarantees that your local medical infrastructure will be overrun.
The structural design of the country literally makes the local mayor or health commissioner the final arbiter of survival.
Yes, it does.
Okay, lesson number 2. Standardized data is the spine of the response.
And this is Wade Hampton Frost's direct legacy.
Right.
Without unified morbidity reporting, strategic resource allocation is completely impossible. Today's surveillance networks, the electronic health records that feed data to the CDC, they are the modern iteration of Frost's house-to-house canvas.
Just much faster.
Exactly. Counting the sick systematically, capturing the mild cases to establish the true denominator is the prerequisite for predicting surges and deploying medical personnel. You cannot fight what you cannot accurately measure.
You have to map the fire before you can put it out. And lesson number 3, maximizing the borrowed power synergy.
This requires seamless coordination. The system functions effectively only when local authorities catch what the federal government throws. The federal government possesses the deep pockets to fund research, recruit personnel, and publish scientific guidelines.
They've got the resources.
But those resources lie dormant without local execution. Community organizers and local leaders must confidently synthesize federal funding and scientific intelligence with their own local executive mandates.
The dashboards tracking localized outbreaks, the standardized reporting protocols at your neighborhood clinic, the very existence of an epidemiology department at your local university. These are the protective walls built directly from the wreckage of the 1918 Canvas surveys.
We learned the hard way.
We did. We mapped the geometry of that terrifying W-shaped curve so that we could recognize it the next time it appeared.
The methodology is the lasting victory here. The capacity to convert chaotic mass death into actionable statistical intelligence.
But, the human cost of acquiring that intelligence was almost unfathomable.
That's heartbreaking.
675,000 individual lives extinguished, families dismantled, a generation hollowed out, and a nation's life expectancy plunging by 12 years in a matter of months.
Just a devastating toll.
We constructed our modern defenses from the raw data of their tragedy. And it leaves me with a final, lingering structural question regarding our modern preparedness.
The underlying tension of the federalist system.
Right. If the definitive lesson of 1918 is that local authority ultimately dictates survival, and if our federal agencies today still operate under that exact same borrowed and bounded advisory framework,
yeah,
how much has the balance of power really shifted for the next airborne killer?
That's the million-dollar question.
We know the virus will mutate again. We know the wave will return. But when it does, have we truly upgraded our legal capacity to stop it from spreading, or have we merely perfected our ability to count the dead?
It is the defining boundary of American public health.
Thank you for joining us on this deep dive.